my gratitude to Dr. Ashish for having me in this wonderful IC. So I'll be starting my presentation. My topic is newer imaging tools for the assessment of ocular surface. So Dr. Ashish explained really well about the role of biomechanics. I'll be focusing on a slightly different area, which is about the ocular surface and issues like dry eye, which where you had a lot of mismatch between the subjective symptoms and the objective signs. So we now have more objective tools to really evaluate the ocular surface and see what's actually going on there. So I'll be dividing the presentation into
within 12 minutes.
I'll do that for sure. So I'll be dividing my presentation into 6 different modalities. And so these include interferometry, nemography, aberrometry, some light scattering properties, non-invasive tear breakup time, and in vivo confocal microscopy. So to begin with, interferometry is basically what helps us visualize the lipid layer of the tear film. The instrument that we use for this is the LipiView 2, but then there are a variety of instruments that are available now which allow us to be able to do that. So what you see here on the left is an individual with a very healthy looking thick lipid layer, and you can see the lipid layer thickness there also is above 100 nanometers. So that's a very healthy lipid layer. But what you see on the right is this individual with a very dull look lipid layer. So you can easily tell by just looking at the image, the interferometric image here, and the lipid layer thickness is also quite low here, which is about 39 nanometers. So this is somebody likely to be having meibomian gland dysfunction, likely to be having evaporative dry eye. And as I said, it has been found that lipid layer thickness correlates quite well with meibomian gland dysfunction. So if you're able to look at the lipid layer, you're able to quantify the extent of meibomian gland disease quite well. Another thing that you get from these interferometers like the LipiView is that you get these images of partial blinks. It will also tell you how many partial blinks an individual is having in the cycle in the duration of the test. So somebody who has a lot of partial blinks, you can go for more intensive lubrication, more viscous lubricants, and more frequent lubricants. The next thing I'll talk about is nemography. So again, this is something which is gaining a lot of prominence. A lot of practitioners have found applications in this. So this helps you visualize the morphology of the meibomian glands quite well. And many of these devices also give you a 3D reconstruction of these glands. So here again, what you see above is somebody with a pretty healthy looking lipid meibomian gland morphology. You can see in the glands, but not much dropouts. Whereas when you look in the image below, you see that that individual has a huge amount of gland dropouts. So that is somebody who's likely been having long-standing chronic meibomian gland dysfunction, which has led to the atrophy of these glands. So this is important to be able to tell because you can base your treatment on that. So we know that when you're treating meibomian gland dysfunction, your first line treatment is warm compresses and manual lid expression. But the issue with these treatments is with just warm compression is that you're not really able to get the optimum temperature at the level of the glands because these glands are at the level of the inner surface of the eyelids, whereas you're applying heat at the external surface, which is why all these expensive modalities like LipiFlow have come about. So the LipiFlow, what it does is it gives heat from the inner surface of the eyelid and gives from the external surface of the eyelids. So you're able to, treat meibomian gland dysfunction a lot better. So this is a 12-minute cycle that lasts. And after that, you get a report at the end of it. And this has been found to be much more efficacious than traditional warm compresses in multiple studies. There are, of course, various other modalities available for the treatment of meibomian gland dysfunction as well. All of them do work well. All of them do involve a cost. They are pretty expensive. So knowing the morphology of the glands helps you decide whether you would want to go for these treatments or not. So somebody who has functional glands is a lot more likely to be able to respond well to treatment. So whereas on the other hand, somebody who has a significant amount of gland dropouts is likely to not respond very well to any treatment, including the LipiFlow. So offering an expensive treatment modality to somebody with significant gland dropouts is probably not the best idea. And this imaging modality helps us identify that. The next modality that I'll be talking about is Wavefront Aberrations. So we know that all kinds of dry eye patients with other ocular surface issues as well have aberrations, have distortions in visual quality. So when you look at their higher order aberrations, you can see serial changes in the tear film, in the aberrations of the eye. So somebody who has tear film instability, as in the case of evaporative dry eye, you'd see an upward curve in the post-blink higher order aberrations. So the aberrations would be okay immediately at the time of the blink, but as the tear film evaporates, you'll see increase in the aberrations. Somebody with low tear volume, constantly higher order aberrations at all times. So this is again something that you can document and quantify. What aberrometry, however, is not able to do is to really tell the scattering of the light that is happening. So there are other instruments available for that, such as the HD analyzer, also known as the OCAS, the Optical Quality Analysis System. So what this does is it measures the scattered light, which the aberrometer is not doing. And this uses double pass retinal imaging to provide an objective analysis of the tear film quality as well. So the above image that you see is that of somebody who has a healthy tear film, who does not have dry eye. So you see very minimal scattering happening. Whereas when you look in the image below, that is somebody where you see a step ladder increase in the objective scatter index, which is the scattering of light. So this is an individual with tear film instability, because you see that the scattering is increasing after the blink. These individuals are those who have tear film insufficiency or aqueous deficiency. So you see consistently increased scattering of light, consistently increased objective scatter index in these individuals. So this really gives you a documentation of the quality of vision and the scattering of light that is happening. The next modality that I'll be talking about is called the non-invasive tear breakup time. So all of us do the tear breakup time in our OPDs. We use fluorescein for that, which of course has some limitations. You cannot simultaneously assess tear breakup over the entire cornea, and the accuracy and repeatability at times is suboptimal. So that is replaced by the NIBUT or the non-invasive breakup times. So what happens here is that video keratographic Meyers Placido discs are reflected onto the cornea, and you see changes in the edge, breaks in the edge of these Meyers happening after a few seconds when the tear breakup happens. So this is what the NIBUT is. And again, so it's a much more objective measure. You can actually watch these Meyers break and document the non-invasive tear breakup time. This has been found to correlate very well with the OSDI scores. This, however, does not correlate very well with different machines. So if you're measuring NIBUT on the keratograph, it might not correlate very well with the ocular surface analyzer, but within one particular machine, it correlates extremely well and is quite repeatable. These machines also give you a measure of the tear meniscus height. So that again has been found to correlate very well with the Schirmer's test value. So a non-invasive way to measure tear film insufficiency or aqueous deficiency in an individual. The last modality that I'll be talking about is in vivo confocal microscopy. So this provides us resolution which is comparable to histological analysis. And the advantage, of course, is that it is non-invasive and real time. So you're able to study the ocular surface and see what is happening at a cellular level in these cases. When you look at this image of an individual with dry eye on the right side and a normal individual on the left side, you see that there are multiple enlarged superficial epithelial cells and loss of superficial epithelial cells in those individuals who have dry eye. What you also see is a dramatic increase of dendritic cells, which are basically inflammatory cells and they're antigen presenting cells. So that again indicates that there is inflammation in the eye secondary to dry eye. There are also a lot of changes that you see in the subbasal nerve plexus in these individuals. In the conjunctiva as well, you see certain changes like the presence of large and more numerous epithelial microcysts on the bulbar conjunctiva. So in terms of clinical applications for confocal microscopy, they are limited, but it really gives us new insights into the etiopathogenesis of dry eye or other ocular surface conditions. So it tells us things which we didn't know earlier. So to summarize, interferometry helps us visualize the lipid layer. Nemography helps us evaluate the meibomian glands and based on that decide our treatment for meibomian gland dysfunction. Wavefront aberrometry and light scattering evaluate visual distortions that are happening secondary to ocular surface abnormalities. Non-invasive tear breakup time is a more accurate, non-invasive and reproducible measure of tear breakup. in vivo confocal microscopy gives us various new insights into understanding dry eye and understanding various ocular surface conditions. Might not be a great clinical tool, but a very, very useful research tool. So there are a whole variety of imaging tools that are available now, which are useful for diagnosis and evaluation of these conditions, and that help us guide treatment. And of course, we will never rule out a good clinical evaluation. All of us understand that, but in synergy with that, these instruments are very useful in the management of ocular surface conditions. So thank you. Thanks a lot.